So up next, coming to the stage here, we got Dr. Arcot. Ro is also a urologic oncologist at the MD Anderson Ochsner Cancer Center here in New Orleans. As you can tell, he works closely with Dr. Rose and myself. Ro comes to us from just up the river in a little town called Memphis, but he's lived his life a bit as a Rolling Stone. I think he went up to New York for undergrad before doing med school. Was at, shoot, I don't have my notes in front of me. Wayne State?
University of Tennessee.
Tennessee, he's a volunteer here. Then he was at Wayne State for his urologic training before doing his urologic oncology training at Duke.
Thanks, Brian. So, like you said, my name is Rohith Arcot. I work at Ochsner Medical Center along with Kyle and Brian. We take care of all the GU oncology patients together. It's nice to have a good team. So today is going to be mostly like a primer on novel biomarkers in renal cell carcinoma. As most of you know, there are no FDA-approved biomarkers in renal cell right now, but there's a lot of work ongoing to try and figure out if there can be one that's useful or not. So I don't have any financial disclosures. Obviously, kidney cancer is an important topic. It's the 8th most common cancer in the United States. There's 80,000 new cases annually and 15,000 deaths, so it's got a significant mortality rate. 20 to 30% are diagnosed with metastatic disease at the time of presentation, and 12% 5-year survival in those that are metastatic when they present. So it's an important cancer topic to discuss. It's even more important because it hits close to home. So here in Louisiana, the rates of kidney cancer are rising, and specifically one of the highest in this heat map in the United States. So we have a significant patient population. Over the last decade, there's been a significant plethora of drugs on the market to treat advanced kidney cancer, and it's really changed the landscape for how kidney cancer is managed when locally advanced or metastatic. The overall response rate back in the early 2000s was 5 to 10%, with progression-free survival of only 2 to 10 months, and overall survival of 5 to 20 months. And as you can see now, that number has blossomed into a far greater number as a result of combination immunotherapy using both VEGF TKIs and immunotherapy combinations, including things like nivolumab and ipilimumab. So some key trials in metastatic RCC with immunotherapy have shown that overall survival is improving. However, complete response rates are still low, and ultimately side effect profile is extremely high. And so that's a good reason for why biomarkers are needed. We need to figure out which therapies, should my patient get? Should they be on IO therapy? Should they be on IO TKI? They want to know, what are the chances that this is actually going to work? Am I going to be one of those people that lives 5 to 10 years? Am I going to be one of those people that lives beyond the clinical trial standard? And then, for patients with localized disease with bad cancer, we still don't know if everybody should be getting pembrolizumab or not. Certainly the KEYNOTE trial that read out this last year showing improvement in overall survival was a big leap forward, but not everybody can tolerate pembrolizumab after localized therapy for their kidney cancer. So definitions for biomarkers: some are diagnostic. We all know what that means. That means diagnosing what we have present. Some are prognostic. This is the definition for this is a clinical or biological characteristic that provides information on likely patient health outcomes irrespective of treatment. So it's important to just define. And then predictive indicates the likely benefit to the patient from a treatment compared to their condition at baseline. So ideally, we would have biomarkers that are both prognostic and predictive. Predictive, obviously, potentially helping us now with all the different therapies that we have available. So some examples of diagnostic, prognostic, and predictive markers: PSMA PET and prostate cancer is diagnostic. Prognostic factors would be clinical staging, PSA level in prostate cancer, sarcomatoid features in renal cancer. And then predictive biomarkers would be ER-positive breast cancer or HER2 overexpression in breast cancer. So hoping to mimic some of those in renal cell. So to date, prognostic models have largely taken into account clinical and demographic and pathologic features of patients and tried to identify overall prognosis. As you can see from this model, this discriminatory model published by Dr. Westerman a couple of years ago, the C-index for any model that's currently available is not very good. It's only about 0.6 to 0.5. So, we need better models to predict prognosis rather than just clinical and demographic information. And that's where biomarkers come in. And there's a laundry list of biomarkers available. We're going to touch on a couple of these very briefly just to prime you for what could be coming down the pipeline. But There are things like histology, immune-mediated, genomic, proteins, DNA, inflammatory, so on and so forth. And we're going to get to some of these next. So probably the most simple one of all the biomarkers would be histology. In Checkmate 214, there was a clear improvement in response to immunotherapy, immune checkpoint inhibition when compared to TKI when looking at patients with sarcomatoid features. And you can see these Kaplan-Meier curves here. There was a response rate of 47% in those that had sarcomatoid features that got ICI therapy. And so, histology is an easy one to get. Most patients do get biopsies, if not resection of their tumors at diagnosis, and so we can easily use that as a surrogate for figuring out which treatment patients should get. In the same trial, interestingly enough, PDL ligand expression has been shown in other tumor types to be indicative of response to immunotherapy. However, in renal cell carcinoma, it hasn't panned out that way. And in the Checkmate 214 trial, PDL1 expression did not change response to Nivo and ipilimumab. And if you focus on the two tan bars at the top there, you'll see that those KM curves overlap, showing that whether patients had less than 1% or greater than 1%, the response was relatively similar. So unfortunately, it's hard for us to use that. And one of the conundrums of why that hasn't panned out in renal cancer as opposed to other cancers is probably because pathology from data sets like the Cleveland Clinic, where they use 50 matched pairs, have shown that immunohistochemical staining techniques can be different between different groups, and that may pose a limitation. But more than that, the primary tumor and the metastatic tumor may need to be biopsied because there was discordance rates between the expression of PDL1 and PDL ligand 1 between the primary and the met in 31%, 22%, and even 20% of staining protocols. So the primary and the metastatic site are not the same. So to talk more about histology, CA9 is a marker of all clear cell carcinoma. It's present in most clear cell tumor types, and there's a new antibody to CA9 called girentuximab that recently got FDA approved. And in this PET imaging phase 3 trial that was basically looking at safety, they were able to show that girentuximab was able to identify clear cell renal carcinoma. And you can see that in the CT scan on the left, the PET in the middle, and then the fused image on the right. Now, it wasn't perfect and could discriminate between benign and malignant tumors, the malignant tumor lighting up red, and in this case, a non-malignant tumor not lighting up on PET. This is a very exciting opportunity for us because the mean sensitivity was 85.5%, specificity 87% with good interreader correlation. And the reason why it's so exciting is not only because it's diagnostic, but because it could be therapeutic. There's a new trial called Starlight 2. It's a phase 2 trial. The study design is quite complicated, but to simplify it for the audience here and for you guys, what you need to know is that they're going to look at whether or not girentuximab plus attached to lutetium-177 plus nivolumab can improve the overall response rate of patients who have metastatic RCC. This is an exciting trial. We're hoping maybe something like this will be present at Oshner in the near future, but this biomarker of CA9 is not only diagnostic, but now being used as a therapeutic intervention. The inclusion criteria is pretty straightforward. Patients are allowed to get multiple lines of immunotherapy prior to enrollment, and the exclusion criteria is pretty standard for all theranostic treatment programs. So what about genomics? Tumor mutational burden has commonly been presented in other tumor types as a predictor of response to immunotherapy, but it hasn't been shown to be the same in renal cell carcinoma as seen in the picture on the left. Whether the tumor mutational burden was high or low, there was no clear benefit. There's some data to suggest that maybe early truncal mutations within tumor types may present a novel avenue for identifying mutational burden. But again, this is a very complicated test. It's not going to be commercially available. It's not going to be at every center. So likely not to be something that we see on the horizon in terms of truncal mutations. This was a trial out of France. It was the Bionic trial. It was a biomarker-driven trial. And what's interesting about this trial is they used DNA and RNA sequencing to figure out if patients' tumors were angiogenic or inflammatory in response. And what they were able to show is that in the image on the left that patients had a better response with nivolumab and ipilimumab when they were in the inflammatory response category based on their DNA and RNA signatures, whereas patients in the figure on the right had better responses to TKI and VEGF therapy if they had more angiogenic factors. Something that could be coming down the pipeline if we did have a specific assay or genomic test to predict which tumor type patients had. Somatic mutations are something that we're able to easily get from tumors. We have Tempest at Osher, and we use it quite regularly. So we can easily sequence primary tumors for mutations that are commonly seen in RCC, such as the ones listed here. And it has been shown previously in a cohort out of Memorial Sloan Kettering that genomic alterations did predict survival among patients with clear cell renal cell carcinoma who were undergoing cytoreductive nephrectomy after 2 cycles of sunitinib. As seen in these Kaplan-Meier curves, BAP1 was not a good predictor of overall survival. However, PRMB1, which is commonly found, didn't show to have a signal one way or another. SED2 and KMDC were both protective and did show improvement over survival when cytoreductive nephrectomy was performed. So something that we might be considering when looking at patients and selecting them for cytoreductive nephrectomy not only might be, did they respond to treatment, but do their tumors have these types of mutations? Clear code 34 is a prognostic risk predictor for localized clear cell carcinoma. This was a novel 34 gene sequence test that was developed out of the University of North Carolina. They used the 34 gene sequence to develop 2 cohorts, CCA and CCB. Basically, the difference was that CCB had 8 specific genes that were mutated that were cell cycle driver genes, and what they were able to show in a localized clear cell renal cell carcinoma cohort was that recurrence-free and cancer-specific survival were different between these 2 cohorts after resection. What's important about this, though, is that if you're going to take somebody to surgery, you might just use a nomogram like the Leibovitz nomogram or the SIGN score or the University UCLA score to determine what's their overall prognosis after surgical resection after clear cell carcinoma. But what ClearCode did was they added ClearCode plus grade and stage, which are part of all these other nomograms, and they were able to show that it outperformed other prognostic models. And you can kind of see that in those bar graphs to the right, down in the bottom, where you have the UCLA score on the left and the SIGN score on the right, and the C indexes were better for the ClearCode model, which included grade and stage, which are a part of both of those other scores. So again, something that might be coming down the pipeline and easy to use, an available commercial assay to predict prognosis after resection of renal cell carcinoma. Unfortunately, one of the limitations to this might be in metastatic disease. So this was a study done out of Mayo. 91 patients with surgically resected clear cell carcinoma. 46 had M0 and 45 had M1. They used ClearCode gene expression microarray on the primary tumor and the metastatic sites, and they found that there was a 43% discordance between primary and mets. And there was 23% discordance between one met and another met. So, what this shows is there's obviously some intertumor heterogeneity, and there's some heterogeneity even between mets in the same patient. So ClearCode might work for localized renal cell carcinoma, probably not going to work in the metastatic setting. So protein biomarkers have been an interesting topic and a hot topic within renal cell carcinoma. Kidney injury molecule 1 has been kind of all throughout the rage and news recently. In this study by Zhu et al. And JCO, I think this was done on a Memorial if I remember correctly, but they used KIM1, which is a circulating protein in blood, for preoperative prediction of renal cell carcinoma, and they compared KIM1 levels in renal cell versus benign masses. They found that KIM1 was overexpressed, and then they wanted to look at preoperative prediction and association with clinical outcomes. Ultimately, they were able to find that KIM1 could not only distinguish between benign and malignant, but when separated to quartiles, predicted overall survival and metastasis-free survival in patients who underwent resection. So to follow up on this, in the InMotion 010 trial, we all know this trial. This was done by Laurence Albagez out of France. She basically showed that 97% of patients from this trial had data to evaluate. 40% had high KIM-1 levels, 60% had low KIM-1 levels. And what she was able to show was that KIM-1, when increased greater than 30%, conferred an overall worse disease-free survival on treatment. Rise in KIM-1 level on treatment led to worse disease-free survival. And atezo, as you can see in the table on the left there, in the KIM-1 high group, improved disease-free survival in patients with KIM-1 high compared to placebo, but not in the KIM-1 low patients. So you needed some expression of this protein to actually have it serve as a significant biomarker. Median KIM-1 levels were higher in any patient that recurred over time. So a potential target. Circulating tumor DNA has been an interesting, has actually shown to be very useful in colorectal cancer and urothelial carcinoma for recurrence. It's questionable as to whether or not it can be used in renal cell carcinoma, and part of that reason is because ctDNA has not been thought to be shed by renal cell carcinoma, especially in localized settings or low-grade disease. In this patient population, you can see that ctDNA positivity was significantly higher in those that had a larger tumor or higher grade. And this was 45 patients with surgically resected clear cell carcinoma. So the association of circulating tumor DNA with patient prognosis and surgically resected disease was studied in 45 patients, and as you can see, with the blue bar being ctDNA negative and the red bars being ctDNA positive, that patients who had ctDNA positivity did far worse than those that were negative. These were both localized and metastatic disease. There were about 45 patients out of Fox Chase. The hazard ratio for recurrence-free survival in positive patients was 3.3, and overall survival was 4.7, so quite high. What's interesting to note also from this study was that all patients with ctDNA positivity after resection had eventual relapse of their disease. And they did study this in both the preoperative and postoperative setting and found that preoperative levels and postoperative levels both correlated with worse overall disease-free and overall survival. This was a study looking at the sensitivity of circulating tumor DNA assays in renal cell carcinoma, and what Basu et al. Did in this, and Dr. Basu's at UAB is a big proponent of ctDNA, was he looked at longitudinal outcomes for 45 patients followed for 48 months with localized or metastatic disease who were being treated with immunotherapy, and he looked at ctDNA changes over time. And he found that there was a 90% correlation with recurrence, 83% concordance with negative ctDNA, and there was a lead time improvement in finding recurrence of about 13.6 weeks when using ctDNA. So I think what's important here is that ctDNA, there might not be an absolute threshold as a marker for when it's positive and negative for predicting recurrence, but using it over time might help us identify patients earlier who are recurring on treatment, who we might need to switch treatment for. However, one caveat would be that the 83% concordance for negative ctDNA might be too low for us to use it as a negative predictive marker. So when it's positive, it's probably positive. When it's negative, there's probably a 20% chance that we're missing those patients who could otherwise be switching treatment, getting more treatment, escalating or de-escalating. So in one more study, this was just an abstract published in the JCO, but ultimately it was the same idea here, looking at ctDNA and response to sunitinib and metastatic RCC. 21 patients, they had planned sunitinib treatment and then cytoreductive nephrectomy, and the objective was to assess ctDNA dynamics following nephrectomy. What they found was that 81% had detectable ctDNA at baseline, 12% had clearance of their ctDNA after cytoreductive nephrectomy, 24% had a decrease, and 59% had an increase. There was a hazard ratio of 3.9 for those with rising ctDNA compared to those who had a decrease, suggesting that we could follow people with ctDNA to predict time to progression and early intervention in those who we might pull off of immunotherapy. So to wrap things up, we'll talk a little bit about inflammatory markers. Inflammatory markers have been used for many years to identify patients at risk for progression from their current cancer diagnosis. This is a very simple test that can be performed by any clinician. It's just platelet to lymphocyte ratio and blood cell counts. And it was shown in this Kaplan-Meier curve that cancer-specific survival was worse in patients who had higher platelet to lymphocyte ratio in non-metastatic clear cell renal cell carcinoma who had treatment. What's interesting is that their model did not hold up very well when considering patients with low risk disease, and you can see that in these top curves. So figure Kaplan-Meier A and Kaplan-Meier B are AJCC, low risk and high risk. And then the Leibovich and Sign score are these other models that are seen in C and D and E and F. And basically what they showed is that unless you had a really big tumor and aggressive disease with high infirmary grade, these inflammatory markers maybe didn't pan out to show the same signal that they did in low risk tumors and predicting prognosis after treatment. So probably not going to be useful for all tumor types or all tumor grades, but could be useful in those with metastatic disease or very large local primary tumors. So gut microbiome has been another hot rage kind of in oncology. A lot of people are using it in urothelial carcinoma, trying to figure out how people are responding to treatments or how well they'll do long term. There's some prognostication factors there in terms of what's going on with our natural flora. This is a really kind of elegant study and beyond my actual scope of education, to be honest with you. But this was a study that was published in the EAU in 2024 looking at fecal transplants from humans into mice to look at response to immunotherapy. Basically what they did was they took mice, they gave them antibiotics to clear their flora. They then instituted them with Renka cell tumors, which is a very common cell line tumor to study renal cell carcinoma. They then challenged them with oral gavage of fecal matter from both non-responding and responding humans to immunotherapy. And the immunotherapy here was, in particular, was nivolumab and ipilimumab. And they showed that they had an improvement in response to their tumors when given these fecal transplants. So you can kind of see that in the pie graph down on the left. Patients, human responders were in the green, and when they gave their fecal matter to the mice, they had improvement in their response to tumors. And you can see that the fecal transplant from non-human responders when given to mice did cause a negative impact on those mice in response to immunotherapy, even though still some of them responded. If you look at the figure at the bottom right in the forest plot, you can see that what they did was they actually measured the bacterial signatures from humans in their fecal matter and those that were responding, and they found a signal for 3 specific bacteria. And when they gave those 3 specific bacteria in the latter part of that chart in the bottom right, you can see that there was improvement in response in both tumor weight and size of their Renka cells that were incubated into the mice over time. And so, it's not only that it's not maybe that just responder fecal matter in responders is important, but maybe there's just specific bacteria that we can give as a probiotic that will improve response to immunotherapy in renal cell carcinoma patients. We're probably a long way off from this, truthfully, but there's so much work being done on it. I can't see that this won't be a part of our regimen in the future. How we'll integrate it will be another question. I'd be remiss if I didn't talk about radiomics and AI because it's everywhere in healthcare now. In this EuroPredict machine learning model, they were able to show that there were approximately 25 markers that the machine learning algorithm could use on a training data set of over 5,000 patients to predict which patients after surgical resection of clear cell carcinoma would benefit from some adjuvant therapy. And you can see in this decision curve analysis on the right, treat all or don't treat any, that the blue curve had better clinical characteristics when using this machine learning model. The machine learning model also outperformed prognostication when comparing it to other known prognostic models, such as the ones we've talked about already, at a C index of 0.81. And so, it outperformed the other ones marginally, but it's still better than what we have. Ultimately, this isn't a slam dunk for saying that machine learning is going to be better than anything else, but suggests that this is probably on the horizon, and larger training data sets can be used to hopefully improve model prediction for who should get treatment after surgical resection. So radiomics is a very complicated topic. We probably really need a radiologist to talk to us about this, but the workflow is quite simple, I guess, if you dumb it down to these 4 steps. There's an image acquisition, there's segmentation of the imaging, then the radiomics comes into play. So after segmentation, certain characteristics of the image, like grayscales, are used to come up with certain signals that are then put into a model that's constructed for use. In this study done out of China, that was published in 2024, their goal was to predict response in metastatic clear cell carcinoma for those patients getting VEGF TKI therapy. They were able to find 12 specific features using segmentation studies on the left with specific radiomic markers. And they combine that with traditional clinical risk factors that we all know to be present, such as T-stage, N-stage, and IMDC score. Importantly, they did not use Fermin grade in their model because not all patients get biopsies, and so they wanted it to be more useful to everybody. And they created a nomogram, and they were able to put patients to high risk and low risk categories to develop a survival analysis. And ultimately, to not get in the weeds here, the AUC curve was highest for the nomogram. So it was 0.83, which was better than the clinical model of 0.75. I think the caveat here is that the clinical model didn't include biopsy, and Fermin grade is an important point of any prognostic model, and so is necrosis. And so there are some limitations to this, but ultimately radiomics may be used with clinical demographic information to better predict response to therapy and survival over time. So personalized medicine is, the goal is to predict oncologic outcomes at diagnosis, hopefully augment surveillance after treatment, help us predict when to escalate or de-escalate treatment in those patients who are living longer than their proposed timelines, and limit financial toxicity to those patients who we're treating. I mean, ultimately, these medicines are expensive. And we hope to, recognize and embrace patient heterogeneity with some of these biomarkers that we've established, and not silo patients into just high, low, or intermediate risk categories. Unfortunately, there are many challenges because there's certain tumor heterogeneity within the tumor itself, as we've shown between primary and metastatic sites. There's a significant cost to these emerging technologies. AI and radiomics are not cheap, and we don't know exactly how much they're going to improve on current clinical models. As we showed in that last slide, an improvement by 0.5 on an AUC curve may not be enough to make it worth investing our money in that avenue. Ultimately, there's lack of standardization for these analysis, and we don't know how we're going to integrate all these markers. How are we going to integrate gut microbiome with radiomics, with gene scores, and which one's going to be better than the other, and how do we sequence them will be important. So in conclusion, precision medicine's here. We need prospective validation studies based on some of these biomarkers, which have largely been done on retrospective data sets to prove their validity. The landscape is vast. It includes everything from genomics to radioligands. And currently there are no commercial available biomarkers present, so we're still waiting for one golden goose to be laid so that we can make changes. But current clinical trials are still using an array of biomarkers for prognostic and predictive purposes, so we'll hope to have some important readouts here in the near future. I want to thank CAGLA and all you guys for your time and listening here today.